Good afternoon. Thank you for joining today's webinar on community supervision and substance use disorders, collaborating for effective training and responses. My name is Mark Stovall. I'm a policy analyst at the Council of State Governments Justice Center, and I will be moderating today's webinar, which is hosted by the National Reentry Resource Center. For today's webinar, we're excited to be featuring 5 panelists: Jac Charlier, Director for Consulting and Training at the Center for Health and Justice at TASC, a pair of speakers from San Joaquin County, California, Rico Molina, Program Manager at San Joaquin County Behavioral Health Services, and Miguel Avila, Senior Deputy Probation Officer, San Joaquin County Probation. And a pair of speakers from Maricopa County, Arizona, Norma Brazda, Probation Officer Supervisor, and Rachel Troutner, SMI Program Manager, La Frontera Impact in Maricopa County. Thanks to all of you for joining the webinar. Before getting started, I'd like to briefly walk through some housekeeping items about the webinar. Anytime during the webinar, you can ask a question by typing it into the Q&A panel on the bottom right-hand portion of your screen. This includes both technical and content-related questions. We will try to reply to technical questions in the chat window as we go. For the content-related questions, we will keep a running list and address them all at the end of the webinar. We will do our best to get through as many questions as possible. And we're also going to be asking you a few questions about community supervision and substance use disorders in your jurisdictions. And we'll explain that process more once we get to that section of the webinar. If you encounter technical or audio problems during this webinar, please call WebEx Technical Support at 1-866-229-3239. Please understand that there are some technical issues that may not be resolved. For this reason, we are recording the webinar, and we will post it on our website at csgjusticecenter.org/NRRC. We should have the webinar posted online by the end of next week. Before starting the content portion of the webinar, I'd like to give you all some background on the Council of State Governments Justice Center and the National Reentry Resource Center, NRRC for short. The Justice Center is a national nonprofit, nonpartisan organization that serves policymakers at the local, state, and federal levels from all branches of government. Staff provides practical, nonpartisan advice and evidence-based, consensus-driven strategies to increase public safety and strengthen communities. The Justice Center operates the NRRC in partnership with the Bureau of Justice Assistance. There are 4 main priorities of the NRRC. Provide a one-stop interactive source of current user-friendly reentry information, identify, document, and promote evidence-based practices, advance the reentry field through training, distance learning, and knowledge development, and deliver individualized targeted technical assistance to Second Chance Act grantees. We are constantly adding new content and resources to our website, and we send out a monthly newsletter that provides information about the latest research, funding opportunities, distance learning events, and other news about reentry. To sign up for the NRRC newsletter and other newsletters, please visit the link on your screen at the end of today's webinar. For an overview of the webinar, we're going to first hear from Jac Charlier, who will do a few quick polling questions of the audience and then discuss how collaboration is key to agencies for communicating with each other and training each other when serving individuals who have substance use disorders and are on community supervision. Then we'll hear from the San Joaquin County team about how this plays out in their jurisdiction in terms of changing responses based on drug of choice, training agency staff, and communication strategies. And then we'll hear from the Maricopa County team about how this works in their jurisdiction. And then we'll have a few minutes for question and answer at the end of the webinar. So first up is Jac Charlier, who is the Director of Consulting and Training for the Center for Health and Justice at TASC. Jac's core experience is in community corrections operations, system theory, and the successful integration of research into practice. He specializes in solutions to drugs and crime from a systems change approach, and he highlights different elements to match the audiences that he works with. Previously, Jac was a deputy chief with Illinois Parole. He started the Parole Division's first female parolee-specific team, first parole leadership and training team, and led the development of the first parole domestic violence training program. Jac is an adjunct criminal justice faculty member at several Chicago area universities. He holds a master's degree in public administration from The Ohio State University. So Jac, I'll go ahead and turn things over to you.
Thank you, Mark, and good afternoon, everybody. It is always a pleasure to be with the Council of State Governments and the grantees and all others who have joined us. So very excited to be here. I am from Chicago, and I am in Chicago, so if during the webinar you hear cheering going on or emergency vehicles in the background, that's all because the Cubs won the World Series, in case you did not know that already. But let's go ahead and get started. We have, as Mark said, three polling questions we're going to ask of you. And what's going to happen is I'm going to go through all three questions, and then we'll say a few words about those. So you see audience poll question number 1 up on your screen now. Then we'll go to number 2, then to number 3, and again, you'll be able to see the responses on the right-hand side of your screen as we do them. So audience poll question number 1, and we'll take about a minute to respond to each question and work through them. So for audience poll question number 1, if you can go ahead and answer that, this is the question that allows you to pick more than one option. So what is the primary drug of choice in your jurisdiction? And again, select more than one option if applicable. So if you can go ahead and do that by clicking on the right-hand side of the screen, you should see the question, and underneath it a series of check boxes. Just go ahead and check box 1 or more for the primary drug of choice in your jurisdiction. If you're in a group setting, which I know some of you are, and you want to talk about it for a few seconds, that totally works so that you can give a group answer if you're not sitting alone at the computer. So go ahead right now and take audience poll question number 1. What is your primary drug of choice in your jurisdiction? All right, we'll give that another 30 seconds. If you're having a little group discussion, that's good. That way you can get some consensus on that. If you know that already, go ahead and, again, click 1 or more boxes. Okay, moving on to audience polling question number 2, and on this one you can only select one answer. So again, if you're with a group, you want to talk about it for a little bit, that absolutely works. Does your agency offer training protocols on substance use disorders and community supervision? Does your agency offer training protocols on substance use disorders and community supervision? And again, go ahead and select the answer that best fits your experience, your jurisdiction, and we know some of you are answering this from the behavioral health side, some from the community supervision side, some from supporter, some from law enforcement, whatever it may be. Go ahead and answer it from your perspective. And we'll take about a minute for responses to come in on that. Again, look at the right-hand side of your screen. You should see all 3 questions up, and just answer question number 2 right now. And again, this is one response only allowed to question number 2. Okay, a few more seconds and we'll move on to question 3. So if you haven't answered, please go ahead and do so. Again, if you're in a group setting, go ahead and make your decision and click in the correct checkbox on the right-hand side of your screen for question number 2. All right, we're going to move on to question number 3. And at the end of question number 3, we're going to hit the submit button once we've answered them all. So audience polling question number 3, how would you rate the level of collaboration between community supervision agencies and substance use disorder treatment providers in your jurisdiction? Again, we've got a 1 through 5, so we've got a Likert scale, and go ahead and click the 1 checkbox that best corresponds to your answer. And if you're in a group, go ahead and have a discussion. We've got a minute for that. How would you rate the level of collaboration between community supervision agencies and substance use disorder treatment providers in your jurisdiction? Once you've completed all 3 questions, in the bottom right-hand corner, go ahead and hit submit so that we can tally the results for all those that are on today's webinar. So let's take a minute and respond to audience poll question number 3. Okay, a few more seconds to finish up. And once you have all 3 questions answered, remember number 1 can have more than 1 checkbox. Number 2 and 3 only 1. But once you are ready, then go ahead and hit submit in the lower right-hand corner and go ahead and do that, and we will be able to tally your responses up then for everybody on the webinar. Okay, good. Thank you very much. Let's see here. So you should now be able to see on the right-hand side the responses to the polling questions. So they're right next. Number 1, 2, and 3 are in order, and it's right next to that. Looking at number 1, primary drug of choice in your jurisdiction. Not surprisingly, obviously, we have a lot of jurisdictions out there dealing with heroin and opiates. That's no surprise. Alcohol, because alcohol is always present in our population, of course. Marijuana, again, not a surprise. Methamphetamines, and prescription opioids, which of course is tied into heroin as we understand it now in its current form. So, but we see the full variety of drugs. Nobody answered hallucinogens, and PCP, it looked like 1 response, or 3 responses on that. So the purpose of this, of course, is to let you know what everybody else is dealing with. It looks like we're all dealing with a lot of different types of drugs, and of course, from a training standpoint, you want to make sure that your drug testing panels is sophisticated enough then in testing for a sufficiently wide range of drugs in the population you're dealing with. Okay, second question, does your agency offer training protocols on substance use disorders? And let's look at, in community supervision, I should say, and great responses here in that we have the, it looks like the number 1 response is we offer training on, we do offer training on substance use disorder and community supervision. So that's excellent. With the grantees that are on here as well as others, but certainly with the grantees, that's the response we would want to see, that training is offered. And for those jurisdictions that don't offer training on either topic, or maybe weren't able to answer A, this webinar will help you get to that point. So it's good you're on today's webinar. And then finally, how would you rate the level of collaboration between community supervision and treatment? And actually, again, it's good you're on the webinar. For everybody who's on, moderate level of collaboration is the most common answer. And strong and very strong together, of course, that's good because together those 2 categories do real well. So that's good to see. And that's, again, part of why we're doing this webinar. So thank you for everybody who took the audience polling, all 3 questions, and for participating in that. We're going to move on, and you won't see the answers anymore. So if you want to take one more quick look at those, do so before we move on. Again, just want to thank everybody who participated in today's poll. All right. I'm going to move the screen forward here. So my opening comments, and each speaker will be brief, is really getting at why do we collaborate. Collaboration is one of those words like partnership that we use, and we mean all sorts of stuff by it, but collaboration has a very specific meaning, and it's important because collaboration is a resource for success. And we'll talk about that in one second, what that means. But we don't want to collaborate on everything because collaboration is very resource intensive. So we don't think of collaboration as a resource. We think of it as a thing we do, maybe a process, but it's resources. And it's resources because it involves people, it involves time, it involves money, it involves buildings, it involves cars, it involves meetings. So it's a resource, and we want to collaborate on those things where those level of resources are needed and not on things where it's not needed. But it's a resource that's used to maximize success in a very specific setting, and that is when you have complex cross-system implementation. Complex cross-system implementation. That's when you absolutely need to collaborate. There's other levels, which we'll get into in a second, of partnership, where if you use too low level of partnership and you're doing complex cross-system implementation, the research says actually you're more likely to fail. So collaboration is a resource for success. That's what it's about. But success when you're doing complex cross-system implementation, and when I say implementation, I'm going to be speaking in a few seconds about implementation science, which is the research that we know about how organizations do implementation to maximize fidelity and success. So I just want to throw that out there. We're not talking about implementation in kind of some experiential way only, but we will be talking briefly about the research around that. So collaboration, it's a resource for success, and because we're talking community supervision and substance use or mental health or trauma or any of that, that is cross-system and that is inherently complex. So what's collaboration? There's generally considered to be 4 levels of partnership. I think you see all those on the screen right now at once. I won't go into the first 3, you can read those, but collaboration, which is in green, is uniquely defined in that there's a set of shared outcomes. There's a set of shared outcomes for the work that's being done. And that's why when we talk about collaboration being cross-system and complex, the main thing that's going to keep you driving is not that there's more tasks to do, because you'll get lost in what the task is and caught in the weeds, as we say, but that we are heading towards a goal that all the organizations that are part of a system are going to be measured against. And that's kind of real tough sometimes, especially if one organization's pulling real well and others are struggling, and yet you don't succeed. One organization can't stand up and say, we achieved something, and the other organizations didn't, because shared outcomes means you either all make it across the finish line together or you don't. So again, collaboration is a resource for success in complex cross-system, and the way we're going to understand whether or not you're collaborating is, do you have system-level shared outcomes? If you don't, you might be doing something that looks like collaboration, but you're not all able to be measured against the same standard, and therefore, by definition, you're actually not collaborating. So if you say, Jack, okay, I get that we're in a complex cross-system situation. I get that we're talking about implementation. It's a big resource. We want to be successful. On what do we collaborate? So we're going to speak very briefly today about 3 drivers of effective implementation. This is based on work that we and many others do around using the research from implementation science. This comes from the National Implementation Research Network. That means just like evidence-based practices like risk, need, responsivity, and peers out of SAMHSA's work on that, or whatever it may be that are evidence-based practices on the justice side or behavioral health side, these 3 items, competency drivers around implementation, organizational drivers for implementation, and leadership driver for implementation, these are based on research, not just on experience, but on research that says these 3 things in play, done correctly, will increase the likelihood of your success when implementing new programs and initiatives. Again, in a cross-system complex environment like all of you are in. So let's talk about the next 3 drivers, and we'll turn it over to the next presenter. So the first driver is competency driver. Competency drivers, there are 3 examples on the screen that you see there. The one in green, training, is the only one that I will be speaking to. Competency drivers is about implementing an intervention as intended. Some of us know this as fidelity to the model. This is extremely critical because, of course, if you're not implementing something against or to what it is you actually wanted to implement, you have no idea if what you're getting as outcomes or what's happening is actually fitting what you wanted to do. So it's implementing against an intervention as intended. Now let me just speak briefly to training. So training, again, it's collaboration. We have a shared outcome. Do you and your system partners have a shared outcome on training? So for example, you may have a shared outcome that says 95% of enrollment, or within 3 days of release from jail or prison or to probation or to parole, 95% will be our shared outcome of getting people enrolled into treatment. Okay, so say that's your shared outcome. one of the evidence-based practices in implementation around training is to do behavioral rehearsals. So if that was your goal, and knowing that every organization has to do its part, but you only succeed if you all cross the finish line together at 95% or up, do you do rehearsals where you actually role play with the treatment person, the community corrections person, the individual themselves, so someone role plays that, or you actually follow the person through, going maybe on the bus route, actually getting on the bus route, getting off the bus route, and again, I know jurisdictions vary, getting to the facility, walking in the waiting room, going through, where you all go through it physically on ground together, and it's not just left to the treatment provider to figure out their piece of the training and the probation department to figure out their piece, but you actually rehearse it all together. And if you do that, and you do that sufficiently and have the feedback loops built in where you're on ground doing that kind of training together, the research says that you will increase your likelihood of success to achieve your shared outcome. So that's called a competency driver, and more on all these drivers, again, which are evidence-based practices in implementation, are available on the website that I mentioned on the first slide. The next type of drivers towards implementation, again, maximizing success using collaboration, is organizational and system environments, creating them in such a way that they work for implementation. We've all worked in organizations where projects and initiatives are started, but the resources are not placed there to have the staff and the participants succeed. So in implementation science, organization drivers are those that say we want to have organizational and system. Organizational is your specific organization, internal, and system is the organizations together, an environment that actually lends itself to doing implementation. You have 3 examples on the screen that you see. I'll speak briefly only about the green one, and that is systems intervention. Systems interventions are critical so that, again, as I referenced earlier, all the staff in an organization have the available financial, organizational, and human resources required to support the work of those who actually are doing implementation. One of the drivers that goes with system interventions, or one of the practices, is that there are multiple champions and opinion leaders outside of or external to those that are doing the direct work. That's really, really important. So if you had a shared outcome that said to ensure that we have a high-level body as well as a medium-level body, so at the manager level, and a line-level organization, so that means line staff from the different organizations. This is unique. You don't see this often, but 2 to 3 different levels of groups across the system that get together. You're looking then at a systems intervention where they each have equal voice and participate in the process of implementation around whatever practice you're putting in, and they have a decision-making seat at the table. Again, they're collectively driving towards the goal, and the line level informs the management level, and the management level informs the executive level, and they are responsive to each other, and each, again, have roles to play in terms of actual decision-making. That's a system intervention. Sometimes what we get is really just one group that oversees it and tries to do all levels at once across the system, and 1 or 2 organizations lead it, and everybody else is kind of left out or partially left out, or at least on the decision-making they're left out. Move towards an organization driver to maximize your success around training and response by having multi-level systems teams that look at it, and again, each have decision-making ability. And the final driver that I'm going to speak about, and we'll turn it over to the next presenter then, is leadership drivers, and these are about the right leadership strategies for your system implementation. Again, this is based on implementation science. Leadership changes over time, we know that. And you'll see on the screen, there's 2 examples of leadership, technical and adaptive. I will speak again just on the one that's highlighted in green, or that's in green, and that's adaptive leadership. By the way, both types of leadership are needed. Technical is really dealing with those knowledge, skills, and abilities that you know and understand now about how to do implementation, that work, and also about the actual content knowledge. Adaptive is responding to those things that are not within your knowledge, skills, and ability, or are just so far beyond anything you've ever done that requires a different type of leadership. But you need both types of leaders, and very few people are both. But adaptive leadership, again, using collaboration towards success based on implementation science, One element of adaptive leadership is that leaders within the organization have clear and frequent communication up and down the channels about successes and concerns. It feeds off the one that I just said just a second ago on the organizational driver. And the idea there is, again, you have a shared outcome. So what would your shared outcome be at that? That we agree that all the members of the system will openly share information about successes and things that aren't going well, even if it's embarrassing to our organization or something we otherwise wouldn't put out. We're going to put that in play. The reason that's critical is because you have a shared outcome. That shared outcome, remember that original one of 95% of people released from jail or prison or whatever your situation is are enrolled in treatment within 3 days. Again, I'm just making that up. If, in fact, you all can only cross the finish line together, you can't cross it separately, together, then this kind of adaptive leadership, where as problems emerge, your leadership in the system and organization are responsive to it and are working towards assisting other organizations so they are successful, not just your organization is successful. We've done everything we could. Our agents and officers are out doing everything, making their contacts, giving the referrals, seeing people, but the treatment end is struggling. You need to help the treatment end in an adaptive leadership environment to improve your success at implementation. So those are just 3 very quick implementation drivers. There's much more on that, but that gives you a taste of how it is that you use implementation science through the vehicle of collaboration to maximize your success for training and response between community supervision and substance use disorders. And with that, I'll say thank you and turn it over to the next presenter.
Jack, thanks so much for polling the audience and for that overview of collaboration and the 3 drivers. So just to introduce the next pair of speakers, Rico Molina is Program Manager at San Joaquin County Behavioral Health Services, BHS. He has been with BHS since 1999 and has been working with the forensic population as a Chief Mental Health Clinician since 2011. Rico holds a Master's in Social Work with an emphasis on public safety. And Miguel Avila is Senior Deputy Probation Officer at San Joaquin County Probation Department. He has been with the department since 2002 and has been working with probationers who have co-occurring substance use and mental disorders for the past 6 years. Miguel holds a Master's in Business Administration. So I'll turn things over to Rico and Miguel.
Hello, everyone.
How's everybody doing today? So we're going to be focusing on the collaboration of our program. Our program, it's called ARCS, Assisted Reentry for Co-Occurring Adults Through Collective Support. So this is a collaborative grant that we've received. This is our 3rd grant that we received for this. And it's in collaboration with Behavioral Health Services, Corrections, and the Probation Department. The program provides pre- and post-release services to male and female adults with co-occurring disorders sentenced to at least 90 days and a 3 to 5 year formal probation grant. It also focuses on offenders with high risk of recidivate, so we do a strong assessment prior, and we do an ONG, the Offender's Need Guide, to determine the level of services and what services they actually need. The phase of our program comes in a couple different phases. Phase 1 is that the program starts while the offenders are in custody, and it's completely voluntary. This is not a forced program. This is something that we feel that the offender should want to do instead of us putting it on them. They receive several screeners, evidence-based screeners and assessments prior to being admitted into the program. They have to have a DSM-IV diagnosis and, like I said, meet the high assessment on the strong. You want to talk about the TCU?
Yeah, so we also do a trauma screening tool just to see if there are any needs that we need to meet as far as symptoms that they're dealing with any sense of trauma that they've experienced, whether they're growing up or whether they were incarcerated. So, you know, the clinician works with the offender to get their buy-in using motivational interviewing techniques, you know, in hopes that they would be interested in receiving the program and all its benefits.
So in phase 2, after we've started programming, we have 2 programs that the clients participate in. One is the CBI for substance abuse, and the other one is seeking safety, both evidence-based programs. During their programming prior to release, we focus on their exit plan, on their treatment plan. So it's a collaboration of probation's case plan and the treatment plan from BHS. This is all in an attempt to get a buy-in from the offender to establish a solid foundation upon release. So we try to, when they're getting released, we try to have every excuse that they've had before on why they couldn't do something taken care of and answered. So we provide housing for them, if possible. So we get them a bed at a sober living environment or at a recovery house, a recovery program. We focus on ground reunification, a lot of resources, even work resources, education, to try to get them to establish a foundation for themselves upon release, so they have a plan so they can hit the ground running. The main focus on starting the programming in custody so that they can finish their evidence-based programming, and like I said, when they get released, they can focus on their treatment plan and case plan goals. The program, it's estimated to take 9 to 12 months, and that's with the in-custody time and the supervision upon the release. So we're supervising them 6 to 9 months upon the release, and then it's, like I said, a 3, depending on the sentence, it's usually a 3-month minimum stay in custody still. So because it is a collaborative program, we work very closely with the Sheriff's Department. The Sheriff's Department in the Honor Farm, in our Honor Farm facility, they have 12 officers that have been trained in motivational interviewing. They understand the TCU trauma screener. They've been they've gone through phase 1 of the crisis intervention training for law enforcement. And not only that, they also understand the seeking safety and evidence-based programming approach. So that was huge for us to get the buy-in from the Sheriff's Department and the correction officers to take a different approach with the offenders as far as trying to talk to them instead of directing them and trying to find out what's going on with them instead of just telling them what they needed to do. This was huge for the correctional facility also in establishing limitations on and future expectations of what they could do. So the correctional officers, we have a classification officer who works with us, who provides us a list of potential clients for ARCs, and after we do the screening and everything like that, the screening for myself and the clinician will move forward with the clientele. So currently, ARCS has a dedicated clinician trained in co-occurring disorders and conduct assessment. She facilitates the group in custody and out of custody. So if the clients are not able to finish the programming while they're in custody, we do provide the classes, the remainder of the classes they will take out of custody. We try to keep it with the one clinician so that we can establish that rapport with the client and just really build that foundation, let them know that they do have a support system. Previously in the facility, there was only one clinician available for the entire jail facility. With ARCS moving into the jail, it provided an additional clinician that they could utilize, which the jail also takes advantage of. There's one, myself, I'm the dedicated probation officer to the ARCS program. I've also been trained in motivational interviewing, evidence-based theory, crisis intervention training for law enforcement, and I don't even know how many other stuff I picked up now from Jac, who I work very close with the clinician. So the main focus of our program is our treatment plan or case plan collaboration. As a team, we meet monthly with the stakeholders, which is the administration from Behavioral Health Services, the lieutenants from the San Joaquin County Jail, and our administration here from the Probation Department. So monthly, we discuss issues in the program, issues with the clients, approaches that we need to take as a team, and how we can, like I said, effectively collaborate for the better of the offender. Besides that, us as line staff, which is myself, the corrections officer, and the clinician, we meet bi-weekly to discuss clients that are out of custody, that are potentially rearrested or need a violation, potential new clients, or any other issue that we may have with current participants who may need a reevaluation for other medication or other issues that may have been going on. Myself and the clinician, we conduct the assessments as offenders as a team. After the strong assessment is done, the addiction severity index is completed, the mental health adult assessment is completed, it takes about 2 hours for us to conduct these interviews together. It says that this is done so we can have the same information from the offender. It also allows for better collaboration of treatment and integration. Besides that, it gives the offender, the client, an opportunity to get to know us a little bit also, so it's not just about them. It's a conversation, which is why some of these assessments take 2 hours, 3 hours. So you're really trying, and this is what makes the collaboration of the treatment plan and case plan a lot easier to integrate. We do cover everything from HIPAA as far as rights of the rights that they have also, so that there's no release of information that's not necessary. Some of our clients know that they can talk to the clinician about certain things that will not get back to me because that is their right. And I'm only aware of things that I need to be aware of, participation in groups, or anything else that I need to address on that level. But there are certain things that we still don't, speak about that we don't have, that the probation necessarily shouldn't be involved in just because of the medical portion of that.
And I think that's very important to address, because when we work with the offenders, we want to present that we are a team and we are a unified front, but yet still know our roles and our boundaries when we're working with the clients. And it really fosters an air of trust with the clients as they work with both with the probation officer and with the clinician.
Because of the differences in the treatment plan and the case plan, our treatment plans and case plan don't always necessarily align. The targeted interventions may be different due to the differences in what the agencies are targeting, reoffend versus mental health treatment. One of the biggest things that we have is that I've noticed working with this program and working with the clinicians is that, when we have an abstain from all substances clause in their conditions of probation, that is completely different when we have a zero-use, no-tolerance policy compared to VHS's treatment plan, where they want to go from using 7 times a week to reducing it to, 2 to 0. So this still allows for that cushion of use, but it's reduced. So that being the case, that is the biggest thing that we've had to come into collaboration with, is on what we're going to do with those type of offenders, because they're still going to be in line with their treatment plan and their case plan. Because of that, due to all this, technical violations of probation are discussed with the ARC clinician, and the decisions and recommendations are made as a team. So we take all that into consideration: what was going on at the time, what caused the relapse in use, what would be better, if it would be better to incarcerate or additional CBI classes for substance abuse, perhaps a residential program. So we try to get the information from everybody involved to try to make the best decision we can, including the client. He also has a say in what they feel the decision or the recommendation needs to be, and that's something that we've been able to do, as far as like, okay, this is what happened, this is what you're telling us. What do you think we need to do for you, or how do you think we can approach this so that it doesn't happen again? So they're giving us ideas also on what they feel that their own recommendation should be for their violation of probation, which at first it was coming from, working in this department now since 2002. When I started, it was black and white, and if you were dirty, you're getting arrested or getting violated. To go from that to asking the clients what they feel their recommendation needs to be for the violation of probation, I think it shows how far this field and our department has come in the way that we are trying to work to reduce recidivism with the client.
And it's important when we do that, cross-training, that you know, we understand each other as far as what language is needed to really understand how we can move forward. You know, when I first got involved with this in 2011, I mean, I really had to know what was a rewards and sanction matrix, you know, and so, and me understanding that helped me understand what probation's point of view is and where they're coming from and why they want to move forward in such a certain direction. So the clinician, you know, that wants to work in this population needs to understand substance abuse, needs to understand behavioral health issues and diagnosis, and also criminal thinking. And so, you know, negotiating all three is important when you're working in collaboration with law enforcement and supervision.
Not only that, but once you really start collaborating with another agency, on top of learning, you know, how they do it and what they do, you also learn the limitations of what they can and cannot do, which is huge, because a lot of times, you know, we'll have an issue and be like, oh, we'll just call probation or we'll just call the BHS issue, when it doesn't necessarily go that way. Like I said, you were able to completely understand the department and what their limitations, what their roles are. Mm-hmm. And that's huge, just being able to understand that about each other and who you're working with. A lot of the times we have expectations of people because of what we think we know about the agency or the department, and once you get to work with them and know them and really try to collaborate, which is just get an understanding of each other, try to get to the same goal, I said it makes it a lot easier to work with each other. Something that I learned working with dual diagnosis is that in dealing with these offenders, it's important to understand that some of the decisions that the offender makes may not necessarily be controlled by them due to mental health status, due to drug-induced psychosis, which is a result of self-medicating. This was a big eye-opener for myself, working in the corrections department, in the corrections field, just having the understanding of that, like it's not just black and white, there are other things that need to take in place. That and the fact that the department has been extremely supportive of what this grant has brought to light, not only for this grant, but for the entire department, for BHS, and for corrections as a whole.
And that's part in addition is that cross-training, first meetings, me making a statement as far as, well, we really can't force medications on folks in the community, just having probation understand that, but we have other strategies to help get the buy-in so we can get more medication compliant from our clients that we work with.
Like it all comes back to this. It is integral that both the clinician, the probation officer work in close collaboration to better serve the offender. Getting as much information as possible from both the probation and the BHS are integral and will allow both staff to target the treatment goals and case plan goals simultaneously. This is, like I said, this is part of the collaboration. I know how many times I've been working with the clinician. The clinician in my program, she's fantastic. We go together on home visits. She's there in a crisis situation for the client, so it's given me another option also on how to target and how to get them to reach their case plans and their treatment goals together. Because we work so close together and because we have the same information about the offender, it's easier for us to work and to determine what we need to do to better serve him or her.
And that really makes it possible to understand when we have shared outcomes, as Jack spoke to earlier about drivers. So, level 4, it's an example of how we operate as a level 4 in our collaboration. We share our outcomes. We have we have an outside evaluator who examines our outcomes and it puts our data together, and it represents us both, the sheriffs and probation and behavioral health good work.
Some of the results that we've had, because this is our third grant for co-occurring disorders, the first grant that we had was called TIGER. It was a Transition-Aid Youth Grounds for Recovery. The initial program focused on 18 to 25-year-olds, and it was able to reduce recidivism in the target population by approximately 7%, or 70%. So this was huge for us. I think In San Joaquin County prior to that, it was about 38%. Besides that, because the officers in the institution were trained in motivational interviewing, they understood the evidence-based programming, the trauma, all the other trainings they had, incidents against staff in the correctional institution were reduced by 80%. This was something that the sheriff loved, is that the incidents against staff, just implementing MI in that area of the facility, reduced incidents by 80%. This helped Corrections Administration provide MI. Now all corrections officers in our county are trained in motivational interviewing throughout the institution. Like I said, this was the result of collaboration, seeing what each agency could do and how a little bit of change could be effective. And that's kind of just what we have right now. But like I said, it's all based on the collaboration, the fact that we all try to have the same common goals. The communication between all of our departments is dramatically improved, not even just for this grant, but just the communication between VHS and probation as a whole has expanded, I believe, and just gotten a lot better, just because we understand our limitations, we understand what we're trying to do. So a lot of this stuff is spread not just from this grant, it's spread throughout the different institutions and facilities that we work with.
Yeah, so it's the stuff that we learned and modeled here through the Tiger and ARCS grant. We have now moved it over at Behavioral Health to various programs and how we implement things. So it's been quite a good journey since the first grant happened.
Thanks so much, Miguel and Rico. That was really great. And just as a reminder for folks who are watching the webinar, feel free to chat in any questions you have into the chat panel on your screen. And so turning next to the Maricopa County folks, we have Norma Brazda. She is Probation Officer Supervisor at Maricopa County. She began her career in the mental health field and worked as a case manager for 3 years. She has worked for Maricopa County Adult Probation for 24 years, the last 13 years as a supervisor. Her assignments include Specialized Mental Health Officer and subsequently a Supervisor of the Mental Health Unit. She is currently assigned to the Garfield Probation Center, which includes a 26-bed residential program to assist men on probation with stable housing and job skills placement. She has her bachelor's degree in criminal justice and psychology and a master's in education. Rachel Troutner is SMI Program Manager at La Frontera Impact. She began as a case manager and has moved on to several positions since, including Clinical Coordinator, Arizona State Hospital Liaison, and Site Administrator. She has worked closely with probation in all arenas of her work, including specialty projects and grants. In her role as the Arizona State Hospital Liaison, Rachel worked largely with the forensic population and worked closely with the forensic assertive community treatment team at the outpatient site. Rachel is now the SMI Program Manager for the same La Frontera Impact Suicide Prevention Center Comunidad Clinic. The clinic is located in downtown Phoenix and serves approximately 1,600 adults with serious mental illness. Rachel holds a bachelor's degree in psychology. And so with that, I'll turn it over to Rachel and to Norma.
Hi, everyone. Are we able now to? Oh. Rachel and I are from Maricopa County. We are the 4th largest county in the U.S. We have 4.2 million. Maricopa County includes 25 cities. And our probation office here in Maricopa County actually has 19 area offices. We have over 52,000 on probation at any one time. Over 21,000 are on standard probation. And of those, we have 800 that are on probation that are diagnosed SMI and on a specialized caseload.
And as far as the behavioral health aspect, Mercy Maricopa Integrated Care is our regional behavioral health authority for Maricopa County. And how Arizona is divided is we have different regions, and the REBA is comprised of, Maricopa County is the largest REBA. And as of right now, that we have approximately 20,000 enrolled adults with SMI. That was as of 2015, and that's 47% of the statewide population. So the REBA basically is they provide oversight, and they're the funding source for all of the behavioral health agencies in Maricopa County.
So our grant was from July 1st, 2013 until March 2015. We got a 6-month extension. And Rachel's going to explain our 3 main goals in our grant.
So ours was a planning and implementation grant in Maricopa County, and it was comprised of adult probation, the forensic ACT team, which is the assertive community treatment team, as part of the then agency was called People of Color Network, Maricopa County Regional Health Behavioral Authority, so the REBA, Correctional Health Services, and then ASU. So we have 3 main goals of the grant: to elevate the knowledge, skills, and abilities of probation officers, detention officers, correctional health staff, judicial staff, and community-based behavioral health services. It was in regards to supervising female offenders as they were released from jail, and they had to have an SMI diagnosis with a co-occurring disorder. We wanted to develop and implement a program of treatment and support services that targets the justice-involved women. Specifically, we focused on gender-specific, trauma-informed, and criminogenic responses. So we had trainings geared towards those areas. We'll talk a little bit more about that in a minute. And then we wanted to enhance the quality, impact, and reach the collaboration amongst all of the parties involved, as well as hopefully make a systematic change that went beyond those who were part of the grant program.
So the majority of our grant was about training, and the original goal was to train over 600 people. We actually had 19 trainings and had more than 729 participants go to these 19 trainings. Part of our grant also was to do a small pilot program to determine if enhancing our skills and our collaborations would make a difference. And we serviced 20 women and we began the case planning while still in custody, brought them out of custody onto probation and the FACT team. And then the probation officer and the case manager worked as a team and collaborated throughout the woman's participation in the grant. And I will say we learned a lot of lessons, but we were successful. Of all the women that participated, only 1 woman was arrested for a new offense, and while she was going through the court process, she was actually found not competent and not restorable. So just to give you an idea of the type of women that we were working with in this grant. So when Rachel and I were trying to discuss the challenges and successes we had during our grant process, what we realized is that probation officers, when we're going through our training, we're taught stages of change, we're taught motivational interviewing. However, we're not until we're on the job do we even discuss resources and maybe what type of substance abuse treatment we should be referring our clients to.
And also on our side, the case managers, we do the same. We train for motivational interviewing, but we don't necessarily train specifically into what substances individuals are using and how to treat that specific substance.
What we learned through the grant was that it was important to individualize the treatment plan for the client. In Arizona, if a client is on an ACT or FACT team, then that team is supposed to give all of the services to the client. And what we realized is the clients we were taking out of custody and placing on the FACT team for this grant actually needed something that was much more structured. And we had to place them, it was an all-day substance abuse treatment program that's available here. And however, the FACT team, when you guys went through your audits, would get dinged because you weren't providing the service and we were outsourcing it. So one thing we learned is sometimes the way we have our system set up is not conducive to what our clients need to get the resources within the community to be successful. also, I'm sure we're not the only county that has this problem, just that we have a lot more people in need of treatment than we have available in our counties.
So one of the trainings that we held was a collaboration process, and this was one of our unique trainings that we think really was successful, where we brought together the probation officers and the case managers on the forensic acts team, as well as correctional health. So we held a training where we basically forced them to intermingle with one another and pair up with one another and develop treatment plans. Probation talked about the OST and the FROST, the tools that they used, and the case managers talked about how we do treatment planning. And we had them sit down together and develop, treatment goals, what would be for their shared offender.
And it was kind of interesting that when Jack was speaking, he said not a true collaboration is when you have all outcomes. And so our systems, and that's one thing that came out of this training, is that our systems were each being funded and have objectives that are similar, but there would be no way to put all this information into like one computer system where we're all working together. So true collaboration, I think, does take where we're all working on common goals, but it's just not available at this time. One of the things that came out of this training, and I think frustrates our staff that are really doing the work, is that all of them are doing something very similar. Like correctional health was doing a case plan for release, which included some of the things that the case manager was doing, and the same thing that the probation officer was doing, but none of that information was being passed amongst each other. And so in our meetings, we tried really hard to make sure that that communication not only started to happen, but would remain available past the time of the grant.
And what we saw and what we ended up doing was pairing a probation officer and a case manager to one another, and that seemed to be successful, where they worked hand in hand in collaboration with the pilot women, the 20 women that were coming out of jail. So they were assigned specifically to a case manager who only worked in turn with an assigned an SMI probation officer. So we helped to develop that collaboration and that communication. And I think it continued past the end of the grant. We forged good relationships, specifically with Norma's team and her probation officer.
So during the trainings, like Rachel said, we had three main topics: gender-responsive services, trauma-informed care, and joint case planning. And the lessons we learned were that our trainings tended to be an overview, and I think really for organizational change, you want it to be specific to your group. It's important to have follow-up trainings, because when people attend the trainings and maybe you get a general overview, it's important to have those follow-ups to assure that people are utilizing the skills they're learning in those bigger trainings you're sending your staff to. And then to make sure those skills learned during the trainings are being implemented and being supported by your managers. Overall, we learned a lot during our grant process. And one thing is, during the grant, we actually applied for the National Institute of Corrections to come out and speak to us and give us some tips on how to improve. And so I would say it's really important just to utilize whatever resources you can find while you're working through your grant. And of course, your TAs are very important as well. So the other thing is that when you're putting your agencies together, it was kind of interesting because you think we're all working on the same on the same vision, but in reality, every agency has something that they're looking for. And I think when you first start, it's really important to develop a shared vision and mission statement, so that even if we all have maybe different agendas that we're working through or that we're hoping comes from the grant, that we all can easily say that this is our shared one. Also, clarify the outcomes for your project. If they're not clarified up front, then through the process, once again, agencies start developing their own outcomes that they're looking for.
And then also to what we learned as well is to, and I believe Jack might have touched upon this, to utilize the line staff. Because we felt we had good collaboration in the beginning, and we all came in kind, different leadership and providers met at a table, and we communicated well with one another, but I think at times we forgot to get the input of the line staff, those probation officers and the case managers that are really there, you know, the forefront doing the hard work. And we thought we knew and captured their needs, but it wasn't until later on in our meetings, as we developed our vision and our outcomes, that we realized we should invite them to these roundtable discussions. So it's real important from the beginning to just make sure you have a membership from every point, from leadership on down to the line staff, so you can have the best results in the end.
And that's what Rachel was just speaking about, that, you know, to include everyone that's going to be involved in the grant at those implementation meetings. And that, you know, the protocol has to come from your executive team, but unless the people that are actually doing the work feel like they have a voice in it all, I don't think you get the buy-in that you really need for collaboration. And so what we'd like to end in is, despite the large amount of protocols, just simply having a willingness to understand one another's roles and system limitations creates better communication and outcome, which in turn benefits the shared client.
Thanks so much, Norma and Rachel. That was really great. So now we have about 20 minutes for questions and answers, and we have a few already, and I want to encourage all of you to chat in any questions, if you have them, into the chat box on your screen. So the first question is, what is the most popular drug of choice in each community, and is there any alteration to training protocol that you've made when new drugs might come into the community or become more popular? Rico and Miguel, do you want to talk about this first? Then we'll have Rachel and Norma talk about it.
Yeah, sure. So let me read the question again. What are good shared outcomes? How can you make sure that everyone agrees with them? Well, we take recidivism rates prior to the program, and we measure how they've been reduced. We take that measurement. We have the stats in front of us right now.
I don't have the stats in front of us right now.
So we come to that consensus of what was agreed upon as far as this is a significant reduction of not only recidivism, treatment completion, recovery. We check with them back a year later. Are they still employed? Are they still if they're going back to school? So we look at terms of a population as a whole, and also individual accomplishments as they continue their recovery. So along with our evaluation data co-op who we hire, we come to that consensus of what is a success, and I think with that, anecdotally and statistically, we did have the one statistic with the sheriff's office and reducing incidences inside the jail. you know, they report to us and respond to us, so that is huge, and we want more of it. So I think that's how we come to that collaboration.
You know, and as far as everybody agreeing with them, I don't think that's necessarily always going to happen. We all have to have that understanding that every department, every agency has different targets that they need to meet. And we just need to be able to understand how we can try to do the best to attain those things for everyone. So it may never be a general agreement like, yeah, this is exactly what we're going to do and we all want the same thing, because that's not how it happens. But you have to have an understanding that maybe we can have a couple different targeted goals. You know, and it may not just be recidivism, but reduction in services necessary for mental health. You know, the amount of times that he's gone to get, you know, to get services that way, or he's been in crisis, reducing those numbers, not necessarily, like I said, having that understanding that you are not going to make this go away completely. There has to be a zone that you can work in together. And that's what you have to, that's why understanding the other agencies that you're working with and who you're collaborating with is important. Just being able to understand, like I said, the limitations and how you can try to get to, like I said, not just to the agreed upon targets, but just a general target zone, like, well, if we do this, is this okay?
Hope we answered that.
Yeah, well, thank you, Rico and Miguel, for talking about the shared outcomes. And Jack, I just wanted to see if you wanted to weigh in on this question as well.
This is a question of different response strategies change based on the drugs that are being picked up through drug testing in a community. Is that what you're saying?
Yeah, you can answer that one.
Yeah. Okay. What was that? I thought that was the question, so I want to make sure. So no, I mean, drug treatment is drug treatment, right? And the only question is that there are two things that are key in drug treatment, kind of generally. One is, do you have the right level of responses for the demand? So do you have enough residential beds, which is not supposed to be a lot of folks, right, about 20%? Do you have enough IOP, OP? And it could be that the treatment modalities for different types of drugs require different mixes of residential, OP, IOP, and of course detox. And I mean clinical detox. I don't mean sweat it out, lay in bed somewhere. But the one drug that came up on the survey in two spots, heroin and prescription opioids, that does have a evidence-based intervention medication-assisted treatment, and the three known drugs around that. So that is a strategy that is used for that. There are drugs for alcohol also. When I say drugs, I should say medications for opiates and heroin, one and the same, and then there are medications for alcohol. So that does have, in fact, a different response strategy to it. But generally, no, not on the behavioral health side. There are different strategies on the supervision side based on drugs. Too long to go into now, but there are differences in how you supervise people using different types of illegal substances or drugs. But generally, treatment is treatment. Look at need, look at demand, look at capacity, find out how much you need of each. That's a data lift, that's data-driven decision-making. And again, for alcohol and opioids or heroin, then medication-assisted treatment comes in, as well as Narcan, the overdose reversal medication should be carried by everybody, including the individuals who are under your supervision and under your watch. They should be given Narcan also.
Great, thanks, Jack. And Rachel and Norma, I just wanted to get your thoughts about either shared outcomes, if you want to talk a little bit more about that, or drugs of choice in Maricopa County.
Sure. Well, as of 2015, with the SMI population, the drug of choice was alcohol, with almost 16%, and then next marijuana, and then methamphetamine, which I think was kind of similar to what we saw in the poll in the beginning of the webinar. But just like what Jack was saying from the behavioral health side, that we kind of treat each person uniquely, so depending on what they're using and where they are in their recovery, we have different treatment options here in Maricopa County. We have the IOPs and partial hospitalizations, and then now actually our ACT teams do have licensed substance abuse counselors on the team. So if a member is enrolled in an ACT team, they can get the one-on-one or the group support right there on-site at our clinic or elsewhere in the community.
And I think Jack said, too, that supervision, I think there's there's the differences. And it's kind of interesting from, you know, when I started in the department over 20 years ago, we directed people not to be on methadone. And a lot of the research and the practices of the departments are changing. So it's kind of interesting to see heroin coming back again. And now our drug court actually is partnering and attempting to use methadone to assist people in staying clean, which is, you know, a whole change of belief systems from when I started as a TO. And I think that's something that departments have to look at as well, is what is going to be the most successful interventions that we use in the community to make sure that our clients are remaining law-abiding.
And Mark, this is Jack. I want to add on something to what was just said. I said I wouldn't go into strategies, but because heroin and opiates came up and was so prevalent, I will quickly say one strategy. So there is a strategy change on the supervision side, right? Behavioral health is behavioral health. Interventions are interventions based on capacity, need, demand. But on the supervision side, for example, people who have heroin addictions, we know from the research out of Washington State and others that you have a 12 to 14 time greater likelihood of overdosing, i.e. dying off heroin, if you're opioid addicted, opioid using disorder, in the first 14 days of release from a custodial situation, especially a long-term one. Won't go into why or the science, but that's what the research says. And of course, based on stats, we find that. That's a higher rate, by the way, than being murdered. Murdered is about 8 times more likely for folks coming out of prisons. Overdose is much higher, 12 to 14. But a different response on the supervision side, and one of the things that I talk about and help jurisdictions with is setting up opiate response teams for folks coming out, so they're very closely monitored to make sure they're alive, literally alive, on an hourly basis in the first 2 weeks. And it's very intensive and involved. The behavioral health side doesn't change, other than they're partnering to that, but the community supervision side absolutely changes when you're dealing with people of opiate addiction. So I wanted to go into that based on the great comments that were just said, and again, realizing the polling data on opioids and prescription were substantial. Polling data is, you know, from the webinar. But that's an example of a supervision strategy that is different based on the type of drug. You wouldn't do that with marijuana, right? That wouldn't be the case.
Hey, this is Miguel Avila and Rico from San Joaquin County. We just wanted to add a little bit to that too. Here in our county, in our area, we have methamphetamine or stimulants as the primary drug of choice, of drug of use. But as far as, and Rico could speak a little bit more about this, as far as admissions and treatment goes, we have the highest amount is for opiate use, and MAT.
And you know, we did. So I did the admission treatment rate for the last federal fiscal year, and for methadone maintenance, we had over 7,800 people, you know, start treatment for methadone maintenance. So you know, so I think it's not only happening in our county, but I can see it's happening almost nationwide.
Yeah, and this just says that how we are still trying to work together. Like, even though our, like I said, primary drug of choice in our area is methamphetamine, we have a high rate of also of opiate medical assisted treatment going on here.
Thanks so much. And then just a follow-up question on that is the use of methamphetamine together with heroin or fentanyl is increasing. Are there any new recovery materials on heroin and fentanyl available?
Well, we're looking into you know, different other strategies as we, you know, as the other presenters know, as we're learning these things, we're constantly meeting to what other medicated assisted treatments are available, looking at evidence-based strategies, and you know, whether it's Suboxone or anything like that. So we are, you know, really working together and planning this whole year, and looking forward how we can intervene with this population next.
And this is Jack. I'll add in, so you said heroin and fentanyl, right, Mark? That's what you brought up?
Yes, that's right.
Yeah, so again, going back to the question or what this is all about, which is collaboration for training and response. Training and response when you get into heroin because of overdose, and that's the same as, I would say, prescription pills, but it's opiates. Heroin, but especially fentanyl, which is about 100 times stronger than street heroin, and carfentanil, which is used for tranquilizing large animals or for sedating them, which is 1,000 to 2,000 times as strong as heroin. Your response strategies better be different if you are getting that in your community. And I'm going to give everybody on the webinar 2 specific ones. Your systems approach, right? We talk about implementation from collaboration, implementation in a complex cross-system world, which is where all the folks on this webinar are living. When we talk, if you have heroin moving into your jurisdiction or there, you need to have fire, EMS, and police into that, because the responders to the people you are working with are more likely going to be them, and you need to have families with them also. That's the first piece where your system expands, because now you are even more complex and cross-system, because carfentanil and fentanyl have a higher rate of death associated with their use. Carfentanil can be almost instantaneous death, where the chest wall becomes rigid right away in a matter of seconds, and of course you can't breathe then. And you go immediately to die, right? And fentanyl, which is, again, 100 times stronger too. So there is a different response, again, based on what this webinar is about. If you are experiencing that, you need to expand your system to first responders and to families. You need to load your folks up with Narcan and give it to the families of the people they're living with. And you need to be in conversation with, collaboratively, your first responders, your public health hospitals, and your emergency rooms. The whole point here, by the way, what success looks like when I talk about collaboration as a resource for success. Success in this arena, if your community dealing with that, is keeping people alive, because the rate of death is much, much higher. So I wanted to throw that in terms of, again, training, and there's training implications to that, obviously, but on response and success and collaboration, it ratchets it up several notches.
Thank you, Jack. And just to follow up, the Substance Abuse and Mental Health Services Administration and the Centers for Disease Control and Prevention have some great resources on emerging trends in heroin and fentanyl use. And another question we have is, are there any new strategies or research materials available in response to the use of synthetic drugs such as K2, spice, or bath salts?
In San Joaquin County here, we haven't targeted this question. It's not something that we've really had an issue with as far as the synthetics or the bath salts or the K2, anything like that. But we try to, even though the treatment isn't going to be the same as a department as a whole, we try to approach it the same way, that obviously there's some type of need or something that we need to do for the client to target whatever is going on there. So the targeted intervention at the end, what we do as a result, is going to be different as far as the treatment. Once we meet the clinician and everything like that, to see what we can do, to see what resources we have available for that. But as far as the way we approach it with anything, it's just, on a case-by-case basis, and see what we need to do strategically for the individual. So we don't have anything generalized for everybody. Like I said, we take these things on a case-by-case basis, and they are definitely individualized treatment plans for the client.
And that's what helps us, drives us to become complex and capable, in our capacity when working with clients and offenders. That's the driving force that makes us more complex as we work with individualized people in their plans.
Yeah, so there's really no cookie-cutter strategy response that we have for this. But like I said, just with any type of intervention that we need, it's geared for the individual.
Yeah, and this is Jack. 2 things on that. So again, I really like the response that was just given. From the behavioral health side, drug treatment is individualized, and drug treatment is drug treatment. It doesn't change for the type of drug generally, right? There is no change. You need to be in treatment. It needs to be clinically assessed using DSM-5 criteria, and you go into the appropriate level of treatment and pray that your community has it. I wanted to throw one other piece though related to this, because K2, bath salts, those are emerging, and communities kind of have different things ebb and flow through them. Think about, from a collaborative standpoint, again, complex cross-system implementation, how many of you have included the police or your local HIDA or DEA which could be state, of course, TA is federal, but there are state versions of it, HIDA, or police in your systems approach to what you're doing. The reason is they put together reports on drugs that they are seeing because they're going to be some of the first to see it. And I'd ask the parallel question, how many of you have your emergency room departments in your systems network as part of your approach? Again, the reason is that the emergency rooms also see people, and they'll get them before you get them because you're getting them out of the justice system, but the police and your emergency rooms will get them first, and they can then give you early warning clues or cues as to what might be coming your way, and then you can prepare through implementation, correct training, or drivers around competency, organization, and leadership changes you need to adjust for what's coming down the pipeline. When the emergency rooms and police start seeing it in numbers, and they'll give you the stats, they put them together all the time, you can bet that in 3 months, 6 months, a year, you're going to be seeing that in your supervision population.
Thanks, Jack. And just another follow-up, SAMHSA and CDC also have some great resources on emerging synthetic drugs. And then just one last question we have is, what trainings do you think were most helpful for community supervision agencies and for the substance use disorder treatment agencies? And so Maricopa and San Joaquin, I know you both talked a lot about the trainings that you had. Rachel and Norma, do you want to start?
I think that anytime we can get trainings done that includes all the players, just sometimes those informal conversations that happen at break time, or like when we did our case plan training, when we can actually understand what the other organization's treatment plan, what their goals, their objectives, what they are capable of doing and not capable of doing, helps us all work together. Not necessarily what we believe another agency can and cannot do is really accurate. And I think when we break down those barriers, it helps agencies work together.
Yeah, just the shared communication. I think the folks in San Joaquin County said the same thing about learning the language of one another. So just having joint trainings, more specific trainings, and try and target as many folks as possible, and just learning, like Norma was saying, that, what barriers, what are the miscommunications and what are the myths that are out there that, your agency, we thought this about you all, that's not accurate. So just learning, what the roles and responsibilities are of each player.
I know when we first started a grant, a lot of times POs would be like, well, you need to get this treatment for our client, and they'd be like, no, it doesn't work that way. And even if they do the referral, it doesn't mean that the REBA's going to approve that they go to that level of care. And then the case managers would get frustrated and be like, well, you need to do something with this client. Why aren't you doing something with this client? And so to understand, what each agency is truly capable of doing and where our, what resources we do have available really helps.
From San Joaquin County, the trainings are essential. The trainings are essential in building the collaboration, not only so that we know each other's information, but also for getting that initial buy-in from everybody. That initial buy-in, that initial resistance that you're going to have from agencies to do something differently, that's probably going to be one of the biggest hurdles that you need to get over, is that now we're changing the way we do business. This isn't what my job was 10 years ago. That resistance that staff will have, it's going to be there. And that's why these trainings are essential to getting the buy-in of all the players involved.
And one good example is, our county, both behavioral health and probation, we both get trained by the University of Cincinnati, cognitive behavioral interventions for substance abuse, and so and implement train the trainers. And so we have trainers that were trained in the University of Cincinnati are now training other probation officers, other behavioral health staff. So everybody is on the same page that when when an offender client is getting CBI, for example, that no matter what person is interacting with that officer, they may not be doing the groups themselves, but they understand what the core principles, and so when they're working with them one-on-one, they can reinforce those coping skills and those principles and to help with relapse prevention. And then that's key that both, that both behavioral health staff and probation understand that as an agency.
And also to be able to understand that this is not going to happen overnight.
Yes.
This is not something that, like, once you say, okay, we're in a collaborative program, that everything changes. It does not happen like that. We had a rough first year, but since then, like I said, it takes about that long to get to understand, know each other, see each other's limitations, what you can and cannot do. And like I said, get that buy-in from staff to see that this is working. Like I said, just be patient, stick to it, and like I said, adjust your program accordingly to the limitations of what everybody can do. Sometimes we write these grants, and they sound amazing, but then you get to it and you're like, I don't know if we can really do that. So you have to make adjustments. You have to keep it as a living document to be able to change it. Contact Mark. We use Mark as a resource every month. He's usually on call with us on every stakeholder meeting that we have, talking about issues, concerns that we have with the grant, what we can, what we cannot change, maybe what we can do, and what we can't do. And like I said, that's essential to have it keep evolving like that.
And this is Jack. I really like what San Joaquin and Maricopa County are putting out as their on-the-ground experience from the implementation science standpoint on training. Again, this will frame out what they're saying. Talked about earlier, make sure you have behavioral rehearsals. You're rehearsing with your entire systems team, not talking, but physically going through the processes that the people who are going to be in the system are going through, and you're all physically standing there from line to leadership, watching it and possibly experiencing it by going through yourself. Go to the places you're telling people to go to, enroll, sign up, spend there an hour, come out. That's one element. Make sure that you're training. Again, this is based on implementation science, maximizing your success, not just experience, evidence-based practices and how to do implementation. Make sure it's skill-based, right? Skill-based. Make sure it's timely, which means it's done actually before you ask staff to start doing it. It sounds goofy, but it happens a lot. You ask staff to start doing stuff, it's called OJT, and that messes things up because they begin to learn wrong way of doing things. And make sure you have accountability for how the training is put together. If your system is probation, treatment, reentry council, local sheriff, and 3 faith-based organizations, every one of those should be participating in the development of training. Even if the training is only for probation, they should all be developing of it, giving it, presenting it, and being part of it. That helps you, and again, collaboration is the path to that. You can't use the lower forms of partnership. They're not sufficient amount of resources. But those are items that are evident, that make the process of training evidence-based.
Great, thank you all. So we're at time, but I just wanted to extend a special thank you to our panelists, to Jack, Miguel, Rico, Rachel, and Norma. Thank you all for a great discussion, and thanks to all of you for attending the webinar. This webinar is being recorded and will be made available on the National Reentry Resource Center website within about a week. Thanks and have a great afternoon.
Thank you.
Thank you.